Greetings and welcome to today's meeting of the Commonwealth Club of California, the place where you're in the know. I am Mark Zitter, CEO of Zitter Health Insights, a healthcare market research firm, and formerly co-founder and CEO of Vital Decisions, a telephone counseling service for patients with life-limiting illness. I'm also a member of the club's Health and Medicine member-led forum and chair of today's program, which is entitled Avoiding the End-of-Life Medical Conveyor Belt. It's now my pleasure to introduce our speaker, Dr. Jessica Newdick-Zitter. I don't know how many people of you have had the opportunity to introduce a spouse in a public forum, but I can assure you it's an opportunity fraught with both professional and personal peril, so I will tread carefully here. I do know her quite well. Dr. Zitter is one of a very small number of physicians in America who actively practices in two very different specialties: critical care, which involves running a hospital intensive care unit, and palliative care, which focuses on comfort rather than cure and is most often used with patients at end of life. A native of Montreal, Dr. Zitter as a teenager moved to California, where she attended Stanford University and went on to medical school at Case Western Reserve. She did her internship and residency in internal medicine at the Brigham and Women's Hospital in Boston. She then returned to California for what seemed to me to be a seemingly endless stream of postgraduate programs, including a Master's of Public Health at UC Berkeley, a pulmonary fellowship, and a critical care fellowship at the University of California, San Francisco. Currently, she's board certified in internal medicine, pulmonary medicine, critical care medicine, and palliative care medicine, and has also practiced as a hospitalist, and maybe most challenging of all, as a summer camp doctor, too. She currently practices both critical care and palliative care at Highland Hospital, the county hospital in Oakland, California. Dr. Zitter has also conducted research that has been published in a variety of medical journals, including the largest epidemiological study of the transmissions of colds aboard airplanes, which she published in the Journal of the American Medical Association back in 2002. She co-founded and was medical director of Vital Decisions, the telephone counseling service I mentioned earlier. More recently, she's been writing in the popular press on issues related to decision-making in the ICU at end of life. She contributes regularly to the New York Times and the Huffington Post, and has written for the Atlantic Monthly, the San Francisco Chronicle, and many other publications. Currently, she is hard at work, and I can attest to that, very hard at work, on her first book to be published by Penguin Random House. At this point, please help me welcome Dr. Jessica Newdick-Zitter.
I definitely owe you one.
This is going to be a conversation, and there'll be plenty of time to ask questions as we go forward later on. But let me start by setting the stage, because the message and the feeling you have about the way medical care is practiced at the end of life is one where I would say overall you're critical of the way it's typically done by doctors. And I want to establish that you're a critic from the inside, not the outside. We established you've done a lot of training at a lot of medical institutions. You also come from quite a family of doctors. Your grandfather was an OBGYN surgeon, father a neurosurgeon, mother an internist. You've got grandparents, you've got uncles and aunts on both sides of the family, physicians and surgeons. It's not surprising you became a doctor. But why the ICU? Why critical care medicine?
Well, if you can't be a brain surgeon, no. Surgery was not for me. It was very intensive, and it was generally what I was trained and wanting to do, to go and do things to patients and to have hyper-skilled abilities to do technological things to help keep people alive. But I chose the most intensive type of subspecialty in the world of internal medicine, and that was intensive care medicine. And it's just really, it's very exciting. It's about life and death. It's about doing things to people. It's really doing something when something needs to be done. And it was very enticing to me.
So I think most of us who are not doctors can relate to that there's a lot of different types of medicine, but certainly among the most dramatic is when you're actually trying to save a life. It's very exciting. And certainly one of the first times, and quite a rite of passage in medical training for many medical students or residents, is code blue. The first time they're in a hospital and a patient's heart stops, and doctors from all over the hospital come running to try to resuscitate that patient. Interestingly, that was perhaps the first time when you started to have a few doubts about the way that end-of-life medicine is practiced. So let me bring us up to date on that, your first code blue.
that was an experience I'll never forget. It was it was probably 3 months into my internship, and I had memorized all of my little protocol cards. We kept them tightly with us in our pockets. And what do we do if we have a bradycardia? What do we do with asystole? What do we do? And every intern and every resident knows that they're going to get called upon to participate in a code blue. And when it happened, I ran out of the room that I was in, and I started running down the hall along with a whole bunch of other residents, and we were being directed down by orderlies, and there were nurses telling us which way to go, like an airplane coming into a berth. And I was thinking about who was going to be in that room that I could help. Was it going to be a 50-year-old man with a heart attack? Would it be a woman, a pregnant woman who was having an asthma attack? And when I entered the room, it was just pure shock, because what I saw on the bed was a body, and that body was yellowed and had clearly been sick for a long time, and had really just was frail and what we call cachectic. There was no muscle or fat on the body at all. And a co-resident was already on the bed doing chest compressions on the body, and I could hear the chest cracking and breaking, and it was gruesome. And then I got pulled into it, and I remember just feeling horror. And about 27 minutes into it, someone said to the resident who was running it, can we call this code now? And the resident said, you know what, let's give it another 3 minutes and just make it an even 30. And it just felt like I was on an assembly line.
So that was an example, perhaps, of what you meant when you titled the session the End-of-Life Medical Conveyor Belt. Tell us more, what is the End-of-Life Medical Conveyor Belt?
Well, that's, to me, what it is it's the notion and the practice of continuing to keep a body alive, even a body that's seriously ill and dying, and using increasing amounts and increasing levels of life support and life-sustaining technology to keep those organs functioning and going. And it just ramps up. Eventually you have a body that is attached to all manner of life support and heading towards death. And unfortunately, too many people do die that way, attached to machines, when it was unlikely that they would ever have helped in the first place. One of the sort of phrases that I've heard, and it's disturbing to me, and it's called, people say, well, peg trach nursing home. It's time to move on, and you've got the patient's somewhat stable, but clearly depending on a complete machine support for life continuation. Let's just put in a feeding tube, that's the peg, and let's put in a trach, which is the surgical attachment to the breathing machine, and let's send them to the nursing home. And I cannot tell you how many patients under my care and around me have gone that route. So that's really what I consider the end-of-life conveyor belt.
Mm-hmm. Now, you are an evangelist at this point for the different type of care you're talking about, but you started out with a traditional medical, not only training, but orientation. At a certain point, you became a convert to a new way of looking at care, at least for a certain segment of patients in the ICU. And like most converts, you had an epiphany. So bring us to that epiphany. It's 10 years later, you're at University Hospital in Newark, New Jersey, still practicing critical care medicine. What happened there?
So I was working at this hospital in the center of Newark, a pretty safety net hospital, and unbeknownst to me, and to my tremendous luck and benefit, it was one of 4 hospitals out of 422 applications that had won a grant from the Robert Wood Johnson Foundation to try to increase communication in the intensive care unit, to try to enhance information transfer to patients and families. And there were these people who would kind of come in to the ICU. There were some nurses and some counselors, and led by this woman named Pat Murphy, who was an advanced practice nurse with palliative care training. Palliative care didn't yet exist. It was 2003. Didn't really become a subspecialty in 2008, until 2008. And Pat would come in and frequently criticize things that we were doing. And she would say, what are you doing to this patient? This is crazy. And I would roll my eyes and think, who is this woman? And one day, I was asked to put in what's called a Quinton catheter, a very large catheter for dialysis into a patient. She had stage 4 breast cancer and was very, very close to death. And they wanted to do dialysis because her kidneys had started to fail. So I went and I got consent from the husband who was sitting in the waiting room, and I made sure that her blood coagulation parameters were normal, and I got the whole room sort of sterilely covered in blue drapes, and got my medical student sitting next to me. The kit was all set up, and the nurse was ready as soon as I got the line in to connect it up. And I looked up and I saw Pat standing in the doorway. And she was just looking at me with this look of disgust. And she went like this. She put her phone up, her hand up like she was holding a phone, and she said, 911, call the police. They're torturing a patient in the ICU at University Hospital.
Wow. How did that make you feel?
It was that whole veneer of doubt and question just cracked. And although I didn't let her know it, or the patient, or the family, I realized that I knew this patient was very close to death. Turned out she would end up dying the next day. And I'm ashamed to say that I honestly didn't have the energy, the know-how, the sophistication, the experience to get her off of that end-of-life conveyor belt at that moment. And so I did put that line in, and it certainly did not change her life, but it changed mine.
You've got plenty more stories, anecdotes, and experiences about this, but it's also been validated and shown in many studies. There was a support trial back in the 1990s, and more recently, Joan Tino's research about end-of-life care. In fact, Joan Tino's more recent research shows that, if anything, end-of-life care may be getting worse, not better, unfortunately. But I think we have to be careful when we're talking about what is care at end of life. Certainly, when we have a healthy patient, we're trying to cure them. That's different from the quality of care we're talking about at end of life. So really, I guess the question is, when cure is not an option, what is good care?
Well, cure is the reason I go to work every day. I love to cure people, and that's one of the best parts of my job. But when a person is at the end of their life, has life-limiting illness, is very severely ill, debilitated, frail, then the decision-making has to not be based on the medical prognosis and the medical function and the physiology of the organs and just doing everything you can to prolong that life. It has to start with the patient. It has to start with what's important to the patient, what their values are, and what their priorities are. And, I think that we, for example, let me give you an example. If a person absolutely knows that they would never want to die alone in a hospital on a breathing machine, then you may be less likely to take the risk of using life-prolonging treatments and having them on the conveyor belt in that environment than you would be to say, let's focus on other goals of care. And it's very unique to each person. There's no right answer. It's just that you need to have those conversations and really understand what the patient-centered decision-making how it should drive the course of care.
Now, I know very often it is there's a constellation of factors that cause things to go wrong or the care to be delivered through the conveyor belt. But more often than not, it's really the physicians who are sometimes driving that without properly educating the patients about their choices. And I remember you illustrated this dramatically in an article you wrote last year. I think it was called Treated to Death, or maybe it was called The 18. Anyway, Treated to Death. Anyway, it was about this came from a story that happened when our family was on vacation in New Jersey. Our family does for fun. We go on vacation in New Jersey, and we were called by a mutual friend who had a mentor advisor of his who was critically ill. How'd you pick up that story?
My friend called me and said, I need your help. My friend is really in a terrible place. And I had known about this friend. He had been diagnosed with pancreatic cancer several months earlier and had been talking with my friend about suggestions and recommendations for him. And he said he's really just in a terrible state. Would you talk to his wife? And so he patched me into a three-way phone call while we were driving along the Long Island Expressway. And she was in a panic. He was delirious. He was incontinent. He was in terrible, terrible pain. And she didn't know what to do. She said, we've got to get him to his chemotherapy appointment tomorrow in New York, and I don't know how we're going to do it. And I said, oh my goodness, it sounds like he's not in any shape for chemotherapy tomorrow. Have you, started to talk to anybody about other types of approaches to his health care? And she was in a panic, and we ended up going there. I ended up going to her house. And he was in a very bad state, and I got more history from her, and it turned out he'd really, really been bedridden now for days, was really, really ill, had been delirious. I mean, this was a man whose body was shutting down. He was dying. And I said to her, listen, I really think that going in and getting more chemotherapy is not the answer. I think we should be starting to focus on his symptoms and trying to improve them and give him some comfort. And she said, oh no, he would never he made me promise that we would do everything to keep him alive, and I would be letting him down. And I said, well, let's call this oncologist. And she had called this oncologist part of her A team. She had collected. They were very smart, effective family, and she had collected an A team at this very high-powered cancer treatment center in New York City. And so I said, let me call this oncologist and tell him and describe to him, doctor to doctor, what your husband looks like, and we can come up together with a plan that makes sense. And she said, but I'm afraid he's going to feel like we're giving up. And I got him on the phone, and we were on speakerphone. And I said to him, look, this is what's happening. And he said, well, he started talking a lot of medicalese. Well, I'm not sure. Is this biliary obstruction or is this? And I said, listen, I understand, I know this is a question, but he's really suffering right now. Do you think that hospice would be an appropriate option for him? And he said, look, if they want to choose hospice, that's up to them. Almost as if, that's giving up. I mean, there was really that tone, and you could see the wife looked like, a little like she was about to be abandoned by her doctor, and she felt very anxious. And I said, okay, how about if we think about a middle ground where we enroll him in hospice, and if he starts to get better, and at that point the doctor said, well, that's not going to happen. I mean, it's funny now thinking back on it, but it was horrible to see the face on this woman when she realized that she had been looking to this doctor to care for her husband, and in fact, all she was getting was treatment. And and we ended up bringing hospice in that evening, and he ended up dying 2 days later in his bed, listening to opera music with his wife lying next to him. So we, hopefully we rescued him off of the end of life conveyor belt. But it was a close one.
But it's rare because, of course, many doctors, specialists because they're geared towards treating organs. And most of us think of ourselves not as a collection of organ systems, but as patients. It's a difference. So one of the reasons, by the way, that all the research shows that doctors and their families die differently from other people. Doctors seek much less care. They seek, a more comfort care and much less CPR, for instance, than others, are because they see it and they think of themselves as people first. They want to be treated as people. No.
And very important to note that those types of approaches that we're talking about, which is to sort of maybe focus more on comfort and palliation of symptoms, have actually been shown, to everyone's surprise, to prolong life, and particularly in things like stage 4 cancer, I believe, and several different kinds of cancers, and some other conditions as well. So it's counterintuitive, but very crucial and important information that doctors seem to know.
Yeah. So even when you decide to not treat anymore, let's just be comfortable, sometimes you actually live longer anyway, and certainly are in much less suffering.
And certainly less likely to die in the hospital on machines.
Yeah. Now, when I talk about this to other people, and as you and I both do frequently, one of the things that comes up is people say, well, okay, I know that if I'm in a certain position, it's a pretty long shot that I would actually be able to be rescued or saved, or even just live for a couple more years at decent quality of life. But why not play the lottery? I mean, this is my life. I mean, I buy a lottery ticket, and I don't expect to win, but if I do, it's great. Does a lottery analogy work with this?
I totally understand it. I can completely understand when we're dealing with life and losing someone, losing a loved one, and most of the time I'm dealing with family members, not the patient, him or herself. And this feeling of just take a chance, or maybe God will work a miracle, or who am I to take away any potential chance? What I think sometimes people aren't considering is the other side of those odds. When you buy a lottery ticket, you have a tiny, tiny chance of winning. But if you don't win, you just have lost a few bucks. In this environment, you have, again, in situations where doctors are telling you we think things are not looking good, you have a tiny, tiny chance of recovering to a place that would probably be acceptable to you. I don't know how tiny. Obviously, it's different from case to case. But in many of the cases I'm talking about, it's very small, if not impossible. And people still say, I'm going to take that chance, but they're not thinking about the other sides of the odds, which are not losing a few bucks, but being committed to a suffering and grisly death.
So that's where the analogy breaks down.
It breaks down.
Yeah. So here I want to back off and just make sure that people don't get the idea that your sense is you should never go for it, and you should, and the answer is for people who have a life-threatening illness that they should always always have palliative care. In fact, what was striking to me when you first started getting into palliative care, I was thinking, how are you going to reconcile this critical care approach, treat, to the palliative care approach? Because they seemed like you had to pick one or the other. And eventually I realized that you reconcile that actually very, very simply, not easily, but very simply. And the simple part is it's about the patient-centeredness. Now, it's so obvious that we don't think about it that if someone comes into the ICU or to the hospital and they can be saved probably through reasonable medical methods, that's what everybody wants, so you do it. What's trickier is on the palliative care situation with a dying patient who may have to make some trade-offs. It becomes a personal issue. This came home. This happened. I remember once when you came home from a hospital you were working at, and you came home from what they call an M&M conference. That's morbidity and mortality, where the medical staff gets together and discusses difficult cases. There had been a woman there who had very serious, who had brain cancer, and there was a discussion of how to treat the person. She was still mentally competent. They were talking about how to treat the patient with this aggressive treatment or that aggressive treatment. And I remember you told me, you raised your hand and you said, has anybody asked the patient what she wants? And there was kind of silence, and the people said, no, we could do this or that and whatever. And a few minutes later, the physician who was running the conference said, okay, so what do we vote for? Shall we treat the patient this way, or shall we not treat the patient and do it Jessica's way? And you raised your hand and you said, I didn't say not to treat the patient. I said, has anybody asked the patient? And it's really a different model. It's not the dichotomy between treat or don't treat. It's saying, what does a patient want at this point? And you've taught me a lot about palliative care, not only being comfort care, but starting out by helping the patient define and identify his or her values and preferences, and then communicate that to the care team and the family. It's a very different model overall.
And I'll tell you that in palliative care, we frequently recommend very aggressive interventions that can be palliative, that can help people with symptom management. And I think people think palliative care means doing less. It actually often doesn't. And there are many times I can think of where when I was the palliative care attending, I've actually recommended to do procedures that the technologists have said, well, wait a minute, she's dying. And I say, this is exactly what she needs. I'm going to tell you a quick story of a woman who was from Guatemala. This was a long time ago, and she had a terrible ovarian cancer, and she had a bowel obstruction, and she kept coming in. She came in twice in 1 week with a terrible bowel obstruction. We'd have to put a tube into her stomach and decompress it, and then she'd go home, and then she would blow up with air again, and it was terribly uncomfortable. And she was vomiting, very uncomfortable. And she desperately wanted to go home to Guatemala to be with her family. That was the most important thing to her. And we asked the interventional radiologist to put what's called a venting gastrostomy. It's a tube that goes into the stomach to decompress the air instead of her vomiting, to decompress it from her stomach so that when she flew up in the plane, she wouldn't expand and possibly get really sick. And we did it, and the people doing the procedure thought we were crazy. And at first, when they did the procedure, she was pretty sick, but she ended up having a tremendous outcome. When I came in her room, she went like this, and she was able to fly home to Guatemala.
Great, great. Well, we've been dumping on doctors a bit about being a cause of this end-of-life conveyor belt, and they certainly have their role. But certainly patients, knowingly or not, play a role there too. And I remember a particularly gruesome example of this was in a piece you wrote last year about a patient that we'll call Vincent. Tell us about that story.
That was a terrible case many, many years ago of a man who I took care of as the ICU attending, who had come in from a nursing home where he was living on a breathing machine with a feeding tube, and he'd been there for, I'd say, 12 or 13 months. And he'd been admitted in and out of the ICU with septic shock, with urinary tract infection or pneumonia or some kind of a skin infection, and we'd treat him, and then we'd send him back to the nursing home. And when I met him for the first time, it was, I don't know, his 8th or 9th admission, and when I saw him, I gasped, because his body had broken down so much that you could actually see his hip socket. I've never seen that before. And it was I will never forget it. And I thought, oh my goodness. And every time they would do a change to his dressing, his eyes would he was in terrible pain. He couldn't communicate with us. He had no family members. And what he did have was an advance directive that he had filled out 10 years prior, that said, do everything, keep my body alive at every possible, and in addition to that, which was what was most notable, was a piece of paper that had been folded over many, many times. It was stapled twice to this advance directive, handwritten in his hand about 10 years earlier. To any doctor that ever will take care of me in the future, I am asking you to prolong my life at all possible costs. And so it was a real, for me, an ethical conundrum, because I couldn't imagine that this man would possibly have known what this was going to look like. There's no way to know it, because we don't give people graphic visuals. We don't even tell people graphically what it will look like if they make that choice, what it's very possibly going to look like. And I don't think he could have known. So I called his conservator, assigned by the state, and I said, I just want you to know that this is, I think, something you need to reassess. She said, well, he's got this advance directive. I said, could you just come down to the hospital and take a look? And she came, and she put on a yellow gown because he was covered with resistant bacteria. And she walked in with me, and she just gasped. And she said, oh my goodness, I can't. And so she went to the judge of the Superior Court of Essex County and said, I'm petitioning for us to reevaluate this case. And the judge said no. And the most striking thing was that when this piece came out sometime in February, I got a letter from this lawyer. She said, I'll never forget that case. I knew exactly who it was, which worried me a little bit, but she realized who it was, and she said that was a case that I'll never forget. But I don't think he could have known.
Yeah, he had a very clear advance directive, and it was being followed, and he didn't have a next of kin to make a different decision for him. Now, I will say that we talk a lot to our friends about advance directives. We have these smart, effective friends, and they typically say, oh, I've got an advance directive, and I wouldn't want that kind of care. I said, don't keep me alive if it's not quite right. So the question is, are they covered? Does that take care of the problem?
Well, there may be some people here who will disagree with me, and I'm sure of that, because I've had a lot of people disagree with me when I've said this in the past. But in a word, no, the advance directive is not adequate. It's a good start, but it is certainly not adequate. And just to let you know, the advance directive consists of two sections. One is identifying, well, it's actually a few more, but two main sections. The first one is identifying who your power of attorney is. Who is going to speak for you if you are not able to speak for yourself? And that's a very important thing to do when you are of sound mind, because these things can, in the drama of the end of life, can become contentious, and a lot of family things can get brought up. And I think it's really important to have that identified early on, so that there isn't any, and let people know early on. So that's one section of the advance directive. The second section is the what's called the instruction directive, the health instruction directive, and it's the part that supposedly tells physicians what this person would want in the event that they became very ill. And that section, the first choice, you can choose between two choices, A or B. The first one says, I have an incurable, I do not want my life prolonged. I would not want my life prolonged if I have an incurable or irreversible condition that will result in my death in a relatively short time. And I can tell you, as an ICU physician, it's not enough information for me, because I don't know if you think a short time is 1 week, 1 month, 6 months. I don't know. The second part is to not prolonging is, I don't want to be prolonged if I become unconscious and to a reasonable degree of medical certainty will not wake up again. Well, what if I could get you to regain consciousness, but you'll be cognitively compromised? I don't know what you would want. If you've had a huge bleed in your brain, and you might have a very good chance of being compromised, would that be an acceptable way for you to live? Would you want us to continue prolonging your life in that way? What if you have profound pain, unremitting pain, we're having trouble getting rid of and managing your pain? How would that affect that decision? So this just isn't enough information for me, and I can tell you that is a real problem, and I've had it happen many, many times. So that's one thing, is that I don't necessarily know what that instruction directive really means when it comes down to making the nitty-gritty decisions that we have to make in the intensive care unit. The other point, which many of you have probably heard about, is that sometimes they just don't show up. When I was in the ICU 2 weeks ago, I had 2 patients who had advanced directives that they had completed that said, please do not prolong my life. We didn't get them until 2 days after they were intubated. And then the third one is what happened to Vincent, which is they're often old and they aren't updated, and we don't really know how your feelings have changed. People write them, and then they kind of, a lot of people, not everybody, but a lot of people will put them away and think, I did my job. I'm being a responsible citizen. So for that reason, I think advance directives as a standalone are not adequate. They're a great start, and it's a great sort of philosophical approach to thinking about these things, but you have to supplement it with other things.
Actually, I promise we'll talk about those other things before the session is over. We'll move on because we've now talked about the role of physicians, the role of patients, but another key actor in all this often is patient families. And this can often be problematic. Sometimes the family is at odds with the patient, right? And I'd say more often than not, it's the patient who says, let me go, and the family doesn't want to let them go. Sometimes the family is at odds with itself. Son and daughter love mom equally, but son says, we got to treat mom, we got to try to save her, and daughter says, that's cruel, we got to let her go. Sometimes the patient is completely competent to be involved in those discussions or lead those discussions. Sometimes the patient is completely out of those discussions. They're too ill, they're incompetent, they're demented, whatever it might be. And sometimes it's somewhere in between. These are all very complicated cases, and of course, as a doctor, you've got to figure out how best to navigate that. I know you had a particularly challenging situation a couple of years ago with a patient with ovarian cancer from another culture who didn't speak the language, and the family and the patient, you were definitely not all on the same page.
This was a very tough case. It was a woman who was very, very ill, and she had come in an emergency basis with a bowel obstruction, and she had been taken to surgery, and she had to go back urgently to a second surgery, and then she was in the ICU on a breathing machine, and the breathing machine was able to be taken off, but then she got sick again and it went back in, and the second time she finally pulled it out herself and surprisingly stabilized, and we could send her to the floor eventually. And she was sort of tired and out of it, but alert enough that she may have been able to participate in the conversation. And I wanted to talk with this family because it was only a matter of time before this woman began to deteriorate again. She has an unremitting, very, very serious cancer. There was just a stopgap Band-Aid that was done with the surgery, but it was only a matter of time before she became very, very ill again. And I wanted to know, what would we do next time she starts to clinically deteriorate? And I also had a sense that she probably wouldn't want to be put back in the intensive care unit because it had been a horrible experience for her, and she was very happy to be back up on the floor with her family around her and in a different environment. So I tried to talk to the family. Said, look, we really don't want you to talk to her. You need to go through us. This is in our culture. People don't talk to the patient. We don't say the word cancer. We don't want to, and I respected that. That's something that I try to be very respectful, and I stayed back. And it went on for several days, and I couldn't get from them any sense of closure on what our decisions would be if her heart stopped, if she developed another emergency obstruction, if she started to have respiratory failure. And I was trying to be, I was trying to be sensitive and delicate, but I would definitely continue to come to the daughter and try to engage her. And finally, she asked the main medical team to ask me to leave the case. And it was hard. She said, this is just too upsetting for me, and I'd rather that the palliative care team not be involved. And that was difficult. And I backed off the case because there was really nothing else for me to do, I felt, at that time. And so about a week later, maybe 2 weeks later, I happened to be in the intensive care unit, and I saw her in the room, and she was getting dialysis, and her hands were tied down. She was not on the breathing machine, but her hands were tied down because they were concerned that she was going to pull at the catheter. And she looked at me, and she saw me and recognized me, and she went like this with her hand, like beckoning me. And I didn't know what to do because I'd been kicked off the case. And I didn't want to be culturally insensitive, and I didn't want to hurt her, and I didn't know what to do. And I made a decision in that moment to walk into the room with a nurse who spoke her language. And I said, "How are you?" And she said, "What's going on?" And I said, "Your family has asked that I speak with them and not with you." I said, "Are you asking, And she looked at me, she said, "Do I have cancer?" And this is a woman who'd been in the hospital now for about 2 months, really sick. And I said, "Yes, you do." And she looked devastated. And I went out of the room to get a chair to bring in to come and sit next to her. And at that moment, her family arrived, and I was across the ICU, and they became enraged. They found out that she told them right away, and they started screaming. And screaming, what kind of a doctor would do this? What kind of a doctor would give this information to a sick woman? And it was horrible and devastating for me.
It's a really hard, obviously a really hard situation. You know, when I was in college, there was a course called ethics, probably was the same thing. And every week would have a different, interesting ethical situation on a lifeboat or something like that. And we'd talk about it and then write a paper. That was fun. But it was abstract, and it was inconsequential, and it was theoretical, and we had a week to discuss it with a bunch of people and write a paper. And you're dealing with things that are life and death issues, highly consequential, unable to prepare for them, and very much in the moment, but are very visible and can easily be second guessed by everybody else afterwards. You had to make that decision to talk to her and what to say to her in that moment without the benefit of having a committee to help you decide. That must be very stressful.
There are no words.
Well, let's one more thing about that overall, because clearly, you know, you've been somewhat critical of doctors and how they practice here. But frankly, even with a doctor who's committed to this, has thought a lot about it, and is trained in it and so forth, it's hard. So I guess the question I have is, why don't doctors in general practice more patient-centered, honest end-of-life care? What are the barriers?
Pretty much everything. I mean, it takes a huge amount of time. I don't know if I can possibly describe to you how much time it takes to sit down and have conversations of this nature and of this magnitude with people who are sick and dying. It's devastating and heartbreaking, and there's a lot of responses that you don't know. You don't know if someone's going to get angry or start yelling at you or just be tremendously disappointed in you, and you're also feeling as a physician like you failed, which is a big part of it. If you can't make somebody better, which is part of our culture. And we don't get paid to do it. So, I mean, I don't personally care. I mean, that's part of my philosophy, but it's not fair to ask a physician to go and have a 1 hour, maybe 2 hour conversation with somebody that may go any which way and you don't know, without actually paying them for it. We pay for all the other procedures that we do without hesitation. But to do this one most, in my opinion, critical piece of work is not compensated. There is some movement. Medicare is considering doing that in 2016, thank goodness. But that's something that's way, way too late in the coming. So, you know, I think that's very important. It goes, again, the other important thing to remember is, you know, if you don't offer a treatment and you say, here's another option, here's another way to go. In my experience, there will often be another doctor who will come in and offer it. And so you look like the naysayer, you look like the bad guy, you look like the pessimist. And that's a hard thing to put on somebody. And, you know, we can get around those things sometimes by trying to coordinate with the other physicians and really have a team approach to it. And that really is important. But it's a tough environment.
I remember when you were doing your pulmonary fellowship, I think this was once, you were learning to use a bronchoscope, which is a kind of a little camera on a device you stick into someone's lungs and go into the bronchioles. And you were like driving, it was like a little bit of a video game. It took you months to learn how to do that well. When doctors learn to do these complex procedures that, you know, sometimes have miraculously positive consequences, that's what they do. When someone comes in who's eligible for that and looks like a good person to explore that with, I would assume it's sort of automatic, you know, again, part of the conveyor belt, just to jump in and do that without thinking necessarily about whether that's in the best interest of a dying patient. You have all kinds of these stories, many of which are really worthy of Greek tragedy. And one of my favorite Greek myths, favorite might be the wrong word, but it's really evocative of this whole issue. If people remember some of the Greek history, there was a goddess named Eos who fell in love with a mortal named Tithonus, I think. And she loved him, but of course mortals die. Main difference between gods and mortals in those days. Gods are pretty screwed up psychologically, but they live forever. So Eos figures she was going to petition Zeus, who was the chief god back then, about making an exception and letting Tithonus live forever. So she petitioned Zeus, and surprise, surprise, he said yes. She was elated, and as she left Zeus's chamber, as she walked the door, suddenly she thought, oh no, I got eternal life. I forgot to ask for eternal health. So over the years, she watched her lover grow older and older and more decrepit, and his body deteriorated more and more, but he could not die. And in some ways, that's such a distressing but apt metaphor for what happens in many of our nation's ICUs and nursing homes.
I just want to quickly tag on to one thing you just said, which is, we get all of these hours and hours of practice with the bronchoscope and with the protocols for Code Blue, but we get very little training on how to talk to patients as doctors. And that's really hopefully changing, and hopefully that's spreading with the work of the palliative care movement that's coming, a very recent movement since 2008, and I think that's exciting, but most young trainees report still that they don't get adequate training in how to talk to patients and break down news and help people with goals of care.
Yeah, it's an important point because I think it's evident to anybody, if you're using a bronchoscope or you're doing neurosurgery, you probably need a lot of years of training for that. It's less apparent, but it's still true that to get really good at these highly difficult conversations, that also takes a lot of training, not a week or two, but years. Well, this is the part of the program where I need to remind the audience that you are listening to the Commonwealth Club of California. I'm Mark Zitter. I'm interviewing Dr. Jessica Zitter. It's also a good time to write your questions down or to pass them in. We have a volunteer who will be going up and down the aisles. This is our son Solomon is helping out. As he says, he was voluntold. Thank you for your help there. While we're doing that, I'll ask one more question while we're collecting the cards, and that is, we promised to give the audience a little bit of help in terms of if advanced directives are nice to have or useful but not sufficient, what else can they do to try to make sure that they're more likely to have their wishes fulfilled at the end of their life?
I do believe you should fill out an advance directive. I think you should fill out advance directives frequently, with some frequency. You should maybe, depending on your personal health status, you should do it every 5 years. If you're sicker and deteriorating, you should consider it maybe every 6 months, every 1 year, but you should be reassessing your goals. But most importantly, you must be taking those surrogates or that surrogate who you've identified and having a real nuanced conversation with them that goes on over hopefully years, where they begin to start to understand who you are as a person and what's important to you. And so that when those times come in the intensive care unit and they're talking to someone like me, they can, with information that I give them about where things look like they're going, they can help figure out whether or not this would be acceptable or would not be acceptable for us to continue working to prolong that life. And so it's really about connecting. It's about nuanced conversations. It's about every time there's a Terry Schiavo case, talking to your family, talking about your feelings about it. There's a great card game called Go Wish. We have a copy of it up here. You can take a look at it, which has just got a bunch of different priorities, and you can stack them in orders that that are important to you. And I think playing that game with your families and your loved ones is very important. I think there are situations where people might want to consider filling out something called a POLST form, and I want to explain really carefully what that is, because even when I've written an article about it, I've found that people don't understand it necessarily. It's called a physician order for life-sustaining treatment, and it's a form that you can get online. It's better if you get it in, it's bright pink usually if you get it from either a social work agency or the hospital, but it's a doctor's order. It's a doctor's order that says, do not do this or do this. It refers to most of the life support treatments that we use. And for people, only for people who are healthy, it is not something that you should be looking at. But for people who are unhealthy, frail, who have an illness that is progressive, you might want to start thinking about whether or not, based on your values and all the things that we've talked about, you might not want to have the use of life support and have your life prolonged when your body becomes very ill. And if that's the case, then you absolutely want to fill out a POLST form. So again, it's not for everybody, but it's for people for whom there is a serious illness that's progressive and they do not feel that it would be a benefit over the burdens that it would cause to be placed on life support.
Great. Well, we have a number of wonderful questions. I promise I will not be able to get to all of them in the time we have. But let's start with a couple of them. Can you comment on less rapidly progressing end-of-life diseases such as Alzheimer's or other neurological diseases?
Yes, that's a very important question. You know, Alzheimer's is unfortunately just too common, and a very, very common disease situation that I see a lot. We have a lot of patients whose bodies, their minds deteriorate before their bodies do, and so they end up a lot of the time in the intensive care unit, particularly because one of the results of Alzheimer's disease is that people start to aspirate food and they develop pneumonias. And so they come to the intensive care unit with very bad pneumonias very frequently. And we see this a lot. And then they often get offered a feeding tube because, you know, if it's not going in through the mouth, might as well put it in through the stomach. And I think it's really important that people understand Alzheimer's disease and understand the natural progression of this illness, because by the time that somebody's body starts to go, with Alzheimer's disease, it's really a recurrent thing. And what we're doing is we're keeping life alive, even if the mind has not continued to function the way it would. And I think people really, in situations like that, and in a different way, progressive neuromuscular dysfunction, that's a different situation, because people there do have cognition, even when their bodies start to fail. And that is why patient-centered decision-making is so critical, because for one person with a progressive neurologic issue, if they can no longer eat on their own or breathe on their own, it may be worth it to them to remain on breathing machines and having a feeding tube if they are able to continue to have what's important to them: cognition, emotional connection, ability to live at home. But they need to investigate to make sure that they will be able to have those things before they start putting themselves on the medical conveyor belt. But with Alzheimer's disease, I think most people, if they really understand the way that the disease goes, they'll understand that eventually people will start to aspirate food and they will develop terrible pneumonias and frequently will then get put on that conveyor belt with dementia. And it's not something that a lot of people would want if they knew about it in advance.
Great. Another question, a couple questions I'll put together. Do you see a role for reimbursement change and financial incentives to support physician acceptance of palliative care referrals, or is it more of a cultural education need? And the related question is, are health insurance companies prepared to change the system to reimburse for palliative care?
That's an excellent question, too. Yes, and yes. I mean, I don't know about the healthcare insurance companies and whether or not they're starting to. I think they are becoming more open to it. I think the data is so clear about palliative care that it is so clearly improves quality of life, quality of death, and it saves money. It's a no-brainer. I mean, there's a study after study after study after study. So it's good for the patients. It's sort of that perfect storm. And so I think most health insurance companies are starting to understand that it's good for everybody, and are supporting it. And I've watched that growth. When we started Vital Decisions, it was interesting. There were a couple of brave health insurance companies, this was in 2004, who said, okay, we'll do it. But they were really worried about being considered a death panel. And that seems to have given way to people just being more willing to health plans being more willing to embrace the concept of palliative care and support it. And I'm seeing it grow in front of my eyes. In terms of culture, cultural change is so critical. I'll tell you, it's tough. It's tough trying to work with colleagues who don't agree with your philosophy. I've had two trainees over the past couple of years just look at me and say, Dr. Zitter, I don't agree with your philosophy of care. That's really hard. It's really hard. And I believe, it makes me feel insecure. I'm going to tell you the honest truth. It's uncomfortable. But I do think we are in serious need of a cultural overhaul in medicine. Yeah.
I was down in the Vital Decisions. First of all, we started that a decade ago with some partners, sold it a few years ago. Through full disclosure, still own a little bit of it, but don't have anything else to do with it. But what most of the facts are that there's dozens of insurance companies that do hire Vital Decisions to have these telephone counseling sessions with patients. And secondly, the model was designed to not involve the doctor, because it's so hard to get the doctor to make, for all the reasons we've talked about, to get the doctor to have these conversations. So this goes right to the member, optional service. Do you want to talk about what's going on and have these kinds of conversations? So that was I still think it's the right model, because I still think it's more likely to have trained counselors do that than to get doctors consistently do this. Is the challenge there. Now, there were a couple questions about perceptions of hospice or palliative care. If people think of that as giving up or no treatment, should we change the names? Or is it more about just training the doctors or both? And maybe having the conversation when people are young and healthy versus when they're very young?
There's been a lot of question about remarketing hospice, and I'm assuming there's some hospice people out here in the audience. Any hands? No hands? Okay. I don't know. I'm curious to hear what they would say. I personally have found people to be very open when I bring up hospice, patients and families, and I bring it up with a very positive spirit, obviously, but I've really not found it to be a huge problem. I'm sorry, what was the other?
Just about the name of it, and do people worry about giving up? If they go to hospice and giving up?
It's everything's in the marketing. I mean, for me, hospice is it's all about what you are doing for a patient. I mean, there's so much that hospice nurses and doctors do for patients that they will never get in any other environment. It's this intense focus on the family, on the bereavement process, on the acceptance process, on any kind of symptom that you could ever imagine. There's no ICU doctor can manage nausea the way a hospice nurse can. Pain management, sort of, so that you can maximize alertness, and these are things that hospice people know how to do much more than anybody else. So for me, it's so easy to sell hospice because it's so great for the right people, not for everybody, obviously, but for people whose goals are to do management of their symptoms, to live as long as they can, but with a real primary focus on managing their quality of life and their symptoms. It's an easy sell, I think. Yeah.
For you, anyway.
That's been my experience a lot of the time. Yeah.
Here's a very tactical question. It says, where do you display the DNR paper?
Oh, the PULSE, is that
this was the DNR.
Well, the DNR is the PULSE. An advanced directive is not a DNR. I just want to make that really clear. The advanced directive is not a doctor's order. A PULSE form is a doctor's order that can say, do not resuscitate. And it's usually, if you can get one, from whether your doctor's office or a social worker or somebody, it's a bright pink form. And people tend to put them on their refrigerators. When the paramedics, if they rush in, they'll go to the refrigerator and check to see. That's sort of something that they tend to do. People who really are even more compulsive about it, and I think I would be if I had a PULSE, would get a medical alert bracelet, because medical alert is recognized as officially by the emergency medical system as a PULSE if it says do not resuscitate. Comfort measures only. There's a variety of things that you can say on it. So I hope that answers that question.
It's a very important distinction to make, that if you have an advanced directive, which is on your fridge, it says do not resuscitate, that's not a doctor's order, and the EMTs will usually resuscitate.
It doesn't say do not resuscitate. An advanced directive, a PULSE form says do not resuscitate. An advanced directive says, I do not want my life to be prolonged. That's not a doctor's order saying do not resuscitate. That's the PULSE form. They're different that way.
Good. A couple questions about communication. Is there a good guidance tool for a person within a family that's got a lot of doctors who may tend to get very involved in these end-of-life decisions and dominate? But of course, since we're talking about things that aren't really so much medical decisions as our personal value decisions, are there good ways for the to empower the non-physician members of the family in this discussion?
Well, that's a great question. I would really recommend, in fact, whoever asked that question, please come up and look at this card game, Go Wish. I think it's terrific, and you can basically put it to your family as, let's play this card game. This is about us all being on the same page and making sure we all understand each other. And it's not about medical things. And hopefully your family will say, okay, I'm willing to try it. I'm hoping my family will be willing to try it. It's a really important thing, and it really helps clarify some of your priorities that really aren't about the medical piece. But that's a tricky one. I can't, every family's got its own politics.
You mentioned the conversation project. There are 5 questions. You can put all these
5 wishes.
5 wishes that they can look at on the web, which are designed to help create these conversations. Because again, you look at the advanced directive form, you think lawyers put it together. This is everything we need, and it's just really hard to apply in many situations in their life. So you want your families, your healthcare proxies, to understand the spirit of what you want, because the letter is rarely going to be sufficient. We just don't have time for a lot more questions, but I've got one I know you didn't really want to address, but too many people want to hear about it, and it's the one about
physician-assisted suicide.
Yeah, and death with dignity, its close cousin overall. So people are saying, what do you think about that?
Well, it's a really tough one. I've shied away about talking about it, and as do a lot of doctors, actually. You know, it's very interesting. I feel such faith in palliative care. I feel that we really, the data show a 92% on average success rate at dealing with symptoms and symptom management. And I am much more comfortable using my medical skills to do everything I can to treat whatever symptom is going on. Again, whether it's shortness of breath or pain, or anxiety, or social disconnection, all the things that come with the diagnosis. I would much rather do everything I can and spend every resource I have to try to maximize the quality of that person's life than to be involved in. But I am also very happy that people are thinking about it. So I'm just, it's a tough one for me, and I don't really have I feel really good about palliative care, and that would be my first, certainly my go-to.
So, in terms of using medical skills to help somebody die, it's a different situation.
It's tough.
Yeah. Okay. One more question here. This is a friend was told that chemo was no longer effective and she can try alternative treatments. What are your opinion of alternative treatments?
Oh, I think I think there's tons of alternative treatments, and I think I actually don't feel like I can speak to that. I'll be happy to speak to people in private about that. It's not really in my expertise, unfortunately.
Got one final question, which is, should you consult a doctor on how to fill out a supplement to an advanced directive?
Oh, you mean in terms of fleshing it out more and making it more clear?
Yeah.
That's an excellent, that question is interesting because I have been trying, and I'm not sure if I should admit this, but I've been trying for many, many years to finalize my advance directive. And I have taken it with me on every family vacation we've gone to. I've written a 3-page document to try to enhance, to make it clearer to people, to explain the spirit. And I still haven't finished it. So I don't know. I really believe, and I sort of believe that for my family to know what I would want, I'm hoping that the collection of the stories that I tell and the things that they know about me and when we play Go Wish is going to be more of a clear direction than what that document's going to say, which I'm having trouble completing.
So your sense is that maybe having a doctor give you advice wouldn't be that helpful because the doctor knows medicine, but doesn't necessarily know your wishes and preferences better than you do.
Yeah.
Okay, good. We're going to have to leave it at that, given our timing. So I would like to thank Dr. Jessica Newdig-Zitter for her comments today. Hold your applause for a moment. We also want to thank our audiences here in San Francisco, as well as those listening to the recording. I'm Mark Zitter, and now this meeting of the Commonwealth Club of California, commemorating its 113th year of enlightened discussion, is adjourned.